This segment, we're joined by Deputy Speaker Dr. Matthew Rohrbach. Matt, can you hear us?
Yes, I can. Good afternoon or good morning.
Good morning. Thanks for joining us. I appreciate your time. I invited you on today because you are the chair of the PEIA committee, and basically you have all the answers, correct?
Well, I can tell you all the statistics, and I can proffer up some solutions, I think. Yeah.
So we have obviously an issue in West Virginia. We've tried to shop out our PEIA. We got no buyers. Premiums are going up. Healthcare costs are going up. We've had some major changes to the program. What do you see moving forward? How do you see us attacking those problems, Matt?
Well, first of all, Happy New Year to you, John, and Mike. And thank you for having me. Obviously, PEIA is a concern to the recipients, and it's also a concern to the state. We want a quality benefit program for our employees. In that regard, we're all aligned. We want credible insurance. So I think I need to go back a little bit and explain kind of where we're at, if you'll give me a little latitude.
Absolutely.
One of the things that really got the ball started with Senate Bill 268 was we received a notice of non-participation from the WVU Hospital in Wheeling.
Could you go back? Senate Bill 268, what is that?
268.
What is that?
Yeah, Senate Bill 268 was the bill that codified the 80-20. Before we tried to keep it at that, Senate Bill 268 did several things. It said it shall be an 80-20 plan. Before it had been, it may be an 80-20 plan. As it was worked out at the time, it was probably about an 85-15 plan. So we said we're getting to the 80-20. Then we hadn't had a premium increase in about 7 or 8 years. So that did prompt a premium increase. The other thing that it did two other important things. We were paying in-state hospitals about 60 to 65% of Medicare. And frankly, the hospitals just said, we're not going to do this anymore. We are getting way below our cost. We can't do this.
And they started to not accept the insurance, correct, Matt?
Well, they served us a notice of non-participation, which as of July the 1st of that year, of 2023, they were going to not take PEIA. So we did the bill in the regular session. I think we did it about 2 days before the session ended. The other thing it did, which was equally important, is it did the duty, it changed the duties of the finance board, and it made them fiduciaries, no longer just advisors. But they have to run this plan with fiduciary responsibilities. It also prescribed that they had to get an actuarial firm to work with them to figure out what the risks were, what the premiums should be. So those were the 4 big elements of that Senate Bill 268. Now, then fast forward to its implementation. We did have that year about a 24% premium increase. Now, if you went back over the 8 years, we hadn't had any increases, and kind of annualized that, it was about a 3% premium increase. But we went so long without one that, yes, it was a rather large increase. We did raise the salary tiers up by 24% to keep people from going into the next tier, because PEIA is a little different type of insurance. The premium that you pay is determined by your salary level. So that it's a bit, and since we're not an ERISA plan, we can do that. Now, so we fast forwarded to where we were in the second extraordinary session this year, PEIA's reserves, we had to build them up because they're required to keep 10% of what they think their losses will be for a year in reserves in order to have capital to operate on. So we put $87 million in the regular session. Now, the other peculiarity about PEIA is there's really two different plans. So there's the PEIA for the state employees, and that's where the state pays 80% and the employees pay 20%. Then there's also what's known as the local plan. Now, these are county, municipalities, even some nonprofits are allowed into that. We have 604, last count I saw, distinct entities buying into that. Now, it accounts for about between 15 and 18% in any given quarter of the number of covered lives through PEIA. Now, our deal with them is a little different. It's not an 80-20 plan, so the state doesn't put any money in that. We charge, say, the Berkeley County Commission, if they are in PEIA, they would get a bill once a month that would cover all the people they want covered. How they distribute the premiums out to their employees, that's up to them. That doesn't have to be an 80-20 plan. It can be whatever they want.
Whatever they've offered to their employees, right?
They are, yeah. Right.
Yeah.
And so what they're really getting into is a lot better. Frankly, it's a lot lower fee schedule than what commercial insurance would give now. But the state doesn't subsidize that. So all we do there on the local plan is we run it to break even. And
what percentage do you say that was, Matt?
It's usually between 15 and 18% of the covered lives. It varies from time to time how many kids in the plan and all that, yeah. But it's between 15 and 18% of the total number of people on PEIA are in these local plans. And so it's an entirely different arrangement. There, the county or the city, they pay 100% of the premium. Now, how they dole out the copay, or how they dole out the part of the cost share to their employees on the premium, entirely up to them. And we've seen it. Some places are 50-50, some are 80-20, some pay it all. Now, when we did, so they got the 24% premium increase as well. To show you how good a deal PEIA still is, so we had 604 covered entities. Not one person, not one entity quit because of the premium increase, because when they went and looked in the market, it's probably still between, most of them came back and told us, it's still between 30 and 40% less than what they could have bought, Aetna or Blue Cross or Cigna, whomever. So it's still a very good deal for them.
So, Matt,
such a good... Well, I'm sorry, go ahead, Mike.
I wanted to just ask, are we the only public employee insurance agency that bases our costs on salary versus healthiness? Is that... That
is a very unusual model. We can't, as we've studied this, because part of my task to the director has been to, study what are other states doing. And a premium-based model based on salary, we only found one or two other public entities in the country that did that. So that is an unusual model in the insurance industry. There's no doubt about it. Most people charge the same premium, and then if they need to give a salary subsidy to the people with lower salaries to help them afford their premiums, they kind of seems like they do it that way. Now, and it may, you say, well, you kind of get back to the same place. Well, kind of and kind of not, because one of the distortions in PEIA is we have some people particularly at universities that are on a state pay line, and it may be not a large part of their salary. And then they're in research grants, or they have faculty practice plans, or they have endowed money, and that's all part of their salary. But the only thing the premium for PEIA is calculated on is that small state pay line. And the reason they need that is to get the sovereign immunity if they're at a medical school, or to get other state benefits if they're with, the faculty of a university or something. So that's a bit of a distortion. I mean, so we've got some people that make, what would be at the highest tier, paying at a relatively modest tier because of this distortion. So that's one of the problems I think this next legislature is going to try to solve.
So if I'm a healthy 25-year-old custodian, and if I get hurt on the job, I'm covered by workers' comp. So if I I can't afford a Cadillac kind of plan, is there an option for me to have the catastrophic plan where $6,000 deductible or whatever it would be that would just cost me penny on the dollars?
High, but yes, their PEIA has multiple plans, and they do have a higher deductible plan. They also have through the health plan in Wheeling, they have a managed care plan. So there's a managed care option, there's a higher deductible option, and then there's the standard PEI that most people take. But we do have people in all of those. So yes, there are options now, and some people do take the higher deductible plan, and it's still for what most people that have a high deductible plan. It's like just catastrophic coverage. It's like I've seen them as high as $10,000 or $15,000. So really, all you're doing is buying catastrophic hospitalization insurance at that point. I think our maximum, and don't hold me to this, but I think the maximum out of pocket on the high deductible plan is like $6,000 before that kicks in. So it's compared to a lot of plans, it's really quite a bit lower, the threshold where it kicks in.
Years ago, I've owned my own businesses for, decades. And I want to say it was in the 1990s, maybe the early 2000s, before Obamacare, that I belonged to an association called the NASET, National Association of Self-Employed, which was an across-state boundaries kind of gathering of small business folks. We got a group rate that was actually pretty affordable at the time. I don't remember what it was. Certainly not the heart-stopping $12,000 a year for each of us that it became between my wife and I. And I belong to Mystery Writers of America, same thing. There are a lot of these big organizations, but it requires crossing state lines to join the health insurance. Is that the states getting in the way of the ability to do that? Is that the federal government? Is it the insurance companies? Why? It seems to me we solve a lot of problems if we just let people combine with various trade associations or whatever and get the coverage that would cross state lines.
You are correct. I think that would be a helpful thing because most, insurance is all about risk. And the larger a pool of premium payers that you have, the more you spread the risk out. I mean, inherently, there are going to be losses. I mean, that's what insurance is all about. So the larger we can spread our base, the better it is for any type of insurance, homeowners, auto, health, whatever. So, yes, I do think that maybe looking at some of the things that would prohibit us from making larger risk pools, although right now PEIA has approximately 215,000 covered lives. So our risk pool is pretty large. And then so some people, you hear a lot of talk, and I'm sure people have called into your show, John, about, well, do we privatize PEIA? Well, I don't know what that would look like because most any health plan employer, once they get above 1,000 employees, they're self-insured. Now, we are 215,000. So we really, by essence, have to be self-insured. And then we hire a third-party administrator. Now, one of the things we're looking at really a lot is our arrangement with PBM. Right now we use Express Scripts. And as you know, the cost of pharmaceuticals has went out of sight. And there were some good articles recently in the Wall Street Journal about how PBMs are kind of distorting the market. I mean, even President-elect Trump has said that's one of the things that he plans on looking at. And there was actually in the original budget reconciliation bill that didn't pass, just the slimmed down version passed. But in that budget reconciliation bill this month, well, in December, that failed, there was major PBM reform.
What is PBM?
It was bipartisan, pharmacy benefit manager. So there was major attempts in Congress to change that distortion. Now, when they went with the slimmed down budget reconciliation, that got jettisoned. But I understand that in the next Congress that's going to start any day now, that's going to come back. So this is something that, frankly, there is actually bipartisan support for in Washington, that we don't see much of that. But that's one of the things, and the Trump administration is all into that. He's already said that we've got to tackle prescription drug prices, because over half of the increase in PEI in the last 3 years has been from prescription drugs costs. And it is really hurting the plan. So in it's the second extraordinary session. Mike can tell you we put $87 million in to pump the reserves of PEI up. On top of that, on top of what we're already paying, probably in the budget the Finance Committee is going to start putting together here in February, we're probably looking next year at another $90 million that we're going to have to put into PEI over and above what we're putting in currently. Now, the employees are upset because the co-pays and deductibles and things are going up, but the state will have also at the same time put almost $180 million additional money in it between the reserve account and the operating account, the premium account, because the state pays 80% and the employees pay 20%. So, we've got every reason in the world to work to try to get these costs down. But the other reason we can't really privatize it is right now we are paying 110% of Medicare. So that was the compromise that we made to keep the hospitals in. Still, most commercial plans would be paying between 150 and 180% of Medicare. So the state is still getting a fantastic bargain from their health care providers, because 110% of Medicare is certainly one of the lowest fee schedules that you'll find in a commercial account. So I can't imagine that we could find an insurance company that could get a healthcare network put together in a private insurance market. They would want to make a profit that the state's not making, so you'd have that in there. And I just can't imagine that providers would still continue to work for 110% of Medicare. So I think where we're at right now with this plan, the state, because of its size, we need to be self-insured. And really because of our fee schedule, I just don't think we can move it into the total private market. Now, some people want that, but if you look at the numbers, it just doesn't support it in any way, shape, or form.
And is it sustainable the way it is, Matt? With $90 million here, well, at some point, is it better to say, let's give the employees the money and let them go to the marketplace? Is that, Well,
you could make that argument, certainly, for some of our lower paid state employees, that they could get probably a lot better deal on the exchange, although those policies are a little spotty. Some of them don't cover as much.
Right.
We actually do have a quality plan now. But that is, you could make that argument. I still think, and one of the things that the director put a slide up in our last presentation, we had him look at other states, and all of them are having, large premium increases just because the cost of health care is just insane right now. And a lot of it gets around these specialty drugs and these pharmacy benefit managers, the GLP-1s. I mean, the cost of the pharmaceutical spend in PEIA and almost every insurance plan has just went crazy. I mean, it's like doubled in the last 3 to 4 years. And that's all just getting reflected through the system as you price your insurance. I mean, the state doesn't make any money off PEIA. We just pay the bills, and our part of the bill is going to go up another, probably around $90 million this year. That's our part.
Let me play devil's advocate a little bit here in terms of the pharmaceuticals in particular. I will tell you up front, I really know very little about any of this, but I've heard through conversations anecdotally that here in West Virginia, Ozempic, for example, is a budget breaker because everybody is using, many people, thousands of people are using it for the off-label purpose of weight loss, whereas it's designed to be an important drug for diabetics. Is it, I could argue, I'm not saying I am, but I could argue that rather than burdening the insurance program with off-label uses for, say, diet control, people could, in fact, eat fewer French fries, right, and move around a little more. So is it entirely unreasonable to disallow certain drugs for off-label uses? And I'm not picking on Ozempic in particular. It's just an example.
Well, actually, it's pick on Ozempic because right now they had a pilot program of Ozempic for weight loss through 3 bariatric centers in the state, and the state got. We were going to spend well over $50 million just on the pilot, and we just had to shut it down. PEIA did that back this past summer. So they no longer cover Ozempic or these similar branded drugs for weight loss alone. If you have diabetes, then that's different. But it's interesting. Across the border in Maryland from where you're at, they have a prescription drug affordability board known as a PDAB. And PDABs are starting to tackle the cost of some of this. And, for the first time this year, Medicare is now negotiating cost. And they started with 10 drugs. So everybody's suffering with the cost of pharmaceuticals. And I'm all for innovation. I'm all for new products. I'm all for life-saving medicines. But we've got to find a way to make them affordable, because right now, I think private insurance plans and public insurance plans, I can tell you it's hurting state Medicaid as well, which is the other state plan we haven't got into, and that's a whole other discussion. I can be on a different time and talk about that, but it's really hurting there. So
Matt, we got about 60 seconds left.
Yeah.
You're in the healthcare field. Do you think that maybe these drug companies shouldn't be able to advertise directly to the public to make these huge swings at these different issues?
Well, that's been one of the things that has been suggested as someone has spent I graduated medical school 40 years ago. And one of the big changes that I've noticed in healthcare is when they started the direct-to-consumer advertising, that really started to ramp up the cost of pharmaceuticals, because the dirty little secret is most people, if you go in and ask your doctor, I saw this on TV and it can help me.
Right.
Most doctors are going to write it for you.
Well, Matt, I want to thank you for your time. I really appreciate you coming on with us. Look forward to talking to you again. I will see you on Sunday. We're up against a break. You're listening to WRNR and TV 10.